Hello everyone. As you know, I'll be moving around the organisation to look at some fantastic services we're providing over the coming months. However, this month I really wanted to concentrate on A&E services because it's really important from a national perspective that we achieve the standards required, and that results in better patient outcomes and improved patient experience. As you know, we just don't want to concentrate on A&E itself because there are a lot of other services and teams that support the flow of patients through the hospital, as well as managing patients out with the hospital to prevent increases in demand within the A&E department. So I just want to look at some of those services and share the experiences of those teams who are providing fantastic services across the board. Well, now we're in the A&E department. I want to introduce Anthony Edwards to you, who's been working with the teams within the department to improve patient flow.
Firstly, the success of the 4-hour target is dependent on the whole organisation in terms of flow and our specialty teams visiting the department. Recent improvements to how we manage patients in acute medicine using the pull model, and also the launch of the GP bay and with additional board rounds have contributed to the success. Along with our clinical support services and portering, they all play an important part in the delivery of the 4-hour quality standard. From an ED perspective, teamwork amongst all disciplines is important, and a common sense of purpose to provide the best possible care to our patients. Following a review with senior clinical colleagues, it was recognised there was a need for greater senior cover in the evening and to provide leadership to the support to the team, which now involves ED consultants working until 10 p.m. weekdays. The urgent care director has also developed a manager of the day to provide support to the clinical teams when required. The introduction of the electronic ED record and the work undertaken by the admin and clerical team in the department has also contributed to the success.
So, as you may be aware, we're heading into those dark winter months now, and we usually see a significant increase in demand. So I want to introduce you to Jo, who's going to tell us a little bit more about how the A&E department are going to manage with that increase in demand.
Winter is a very challenging time in the ED, with high demand on the service, whilst acuity also increases. This means we often need to treat more patients and for a longer period of time. We sustain this pressure by ensuring a strong team approach and support one another on these challenging days. In order to support the team, we have recently recruited some paediatric nurses along with ED sisters. We have recently appointed an additional EMP to provide greater coverage for minor illnesses and injuries. We also have newly qualified nurses on the preceptorship scheme. This is supported by nursing staff and our practice-based educator, Karen.
You'll have heard me talk about the digital health service that we provide over the last few months. However, I want to allow the team to tell you a little bit more about what they are doing. It's been fantastic in terms of reducing demand on our hospital services and providing a better service to our communities. The service did start off by linking the nursing homes that we have within Tameside and Glossop to the digital health service. However, due to the success in that arena, we've now expanded that service to other areas. And I would like now to introduce the team to tell you a little bit more about what they're doing.
So, as Karen said, we have 45 nursing residential homes, but she has asked me to speak about the other work that Digital Health do. We take all the calls from Tameside and Glossop for the RMO here at the hospital and divert down various pathways to avoid accident and emergency. So, for example, they might go to the ambulatory care unit or they might go to the integrated adult assessment unit. Other work that we're doing at the moment is we're currently on a pilot scheme with the North West Ambulance Service. That involves us responding into the C3 web stack for categories 4, 5 and 6. We intercept the ambulance, we go out to the home, patient's home, that could be any patient in Tameside and Glossop, assess them, implement the care provision via a community service provider, thus avoiding an ambulance having to attend and attending to accident and emergency. We also look after the chronic long-term conditions in conjunction with the extensivist team. We monitor the telehealth of these patients via a remote access. The observations are taken and recorded and sent down the ADSL to us, and again we can intervene without that patient having to come to accident and emergency.
As you will know, over the last few weeks, I've been letting you know what we're doing within the A&E department to increase its capacity. So we've been undertaking some estates work to enable us to create that additional capacity to improve patient flow. So can I introduce you to Dr. Kamara, who will tell you a little bit about what we are doing.
Excited that from December we will be able to expand the emergency department into what is currently orthopedic outpatients. This new facility will allow our GP colleagues and our nurse practitioners to help a dedicated place to see minor injuries and illnesses. This will allow the current minors area to support the majors function and ambulance triage as well as treatment, which will mean improvements to ambulance handover. The changes will also mean less patients on the hospital corridor and improve the patient experience. We've recently been working with the triage team on the development of the Delphi model, which assists in the streaming of patients to ensure they are seen by the right healthcare team or professionals at the very first time of asking.
As you will be aware, the hospital has an admission avoidance team, and this team provides fantastic services to actually help us manage demand and reduce the pressures on the A&E department. So I'd like now to introduce you to Rachel, who will tell us a little bit about those services.
I'm Rachel Perfect, and myself and John Howard, social worker, we work down in A&E as well as up on AMU and IAU. We are part of the admission avoidance team, which consists of nurses, therapists and social workers. We work between A&E and AMU and IAU, responding to admissions to the unit, and we facilitate discharges where we can, perhaps for people where an acute bed isn't the most appropriate place for them at that time in their care. We refer on to our community, locality services and teams. We link in with digital health. We utilise voluntary agencies and our neighbourhood colleagues to facilitate discharges and ensure that we're giving our patients the right care at the right time in the right place.
One of the other main things we try to do is to start discharge planning at the point of admission by monitoring patients that come in through A&E and cross-checking them against social services database to see the patients are known to social services, have they got a package of care that can be restarted, does it need to be suspended, are they open to a social work team, we inform the social workers that the patient is now in hospital, and then we follow that patient through the system, gather information to help us to a speedy discharge once the time is ready.
Well, I hope you've really enjoyed hearing about the fantastic work that some of our teams are undertaking to address the demands on the A&E department, whilst making sure that we improve the patient's experience and the care they receive. So this is my first video blog, so I'd really like to hear about your comments because we want to constantly look at different ways of communicating with you to inform you what's going on within the organisation. So we do want to know whether this has been a success or not. So please let me know.